Okay, if you're a medical trainee, you know that managing a massive bleed is one of the most high-stress situations imaginable. You need answers, and you need them right now. Well, today, we're going to pull back the curtain on a really powerful tool that gives you those answers in real time, thromboelastography, or as you'll hear it called, TEG.
So, I want you to picture this. You're in the trauma bay, maybe the operating room. Your patient is bleeding out. You know you have to give blood products, but which ones? Platelets, plasma, cryo? The standard labs, your PT, your INR, your platelet count, those could take an hour to get back from the lab. And in a massive hemorrhage, well, an hour can feel like an eternity.
And that right there, that's the information gap. Your standard labs are slow, and they only give you these little isolated snapshots of what's going on. They tell you nothing about how well the platelets are actually working, and they can't tell you if a clot is breaking down too quickly, a process called fibrinolysis. But TEG, it's the complete opposite. It's fast, you got results at the bedside, and it gives you this global assessment. It's kind of like watching a movie of the entire clot being born, getting strong, and eventually breaking down.
So here's our game plan for today. First, we'll talk about the coagulation crisis, why TEG is so important in the first place. Then we'll get into what TEG actually is. The real heart of this will be decoding the TEG tracing. That's the key skill. From there, we'll see how that tracing leads you directly to a treatment. And finally, we'll wrap up with a realistic look at its promise, but also its limitations.
All right, let's dive into Section 1, the coagulation crisis, and why we really need more than just the basic labs.
I mean, the stakes just couldn't be higher. Worldwide, we see almost 6 million deaths from injuries every year. And of those, a staggering 30 to 40% are due to massive bleeding. This condition, where the body just loses its ability to form a clot, is a massive, massive killer.
And this is exactly why those traditional tests can be so frustrating in an emergency. They're just too slow, and they have these huge blind spots, right? They don't see platelet function, they don't see fibrinolysis, and this information gap can lead to what we call improperly balanced transfusions. You're basically guessing, giving products that might not help, wasting a precious resource, and maybe even hurting the patient.
So that brings us to Section 2, Introducing TEG, a Better View. Remember that movie analogy, a real-time movie of clot formation?
Okay, here's the textbook definition. It talks about dynamic viscoelastic properties. What on earth does that mean? Well, think of it this way. It's a measure of your blood's ability to go from a liquid to a solid gel, the clot. And not just that, it also measures the physical strength of that clot over time, so you get this complete global picture of hemostasis. And this isn't some brand new futuristic technology. TEG was actually invented way back in 1948. Its first major use in the clinic was during the Vietnam War, helping guide transfusions for soldiers. After that, it proved its worth in really complex surgeries like liver transplants and cardiac bypass, and its use has just been growing ever since.
So how does the machine actually work? It's really quite clever. You take a little bit of your patient's blood and put it in this tiny cup. The cup then starts to gently twist back and forth. It oscillates. There's a pin that's suspended down into the blood, but it isn't touching the sides of the cup. At first, nothing happens, right? The liquid blood just sloshes around it. But as fibrin strands start to form a clot, they create a physical bridge between that moving cup and the pin. Suddenly, the pin starts to move too, and a little detector tracks its motion, which is what creates that graph we see on the screen.
Now for the really important part, Section 3, Decoding the TEG tracing. This is where we learn to find the clues in the curve. This table, right here, is basically the TEG decoder ring. It's everything. The tracing gives us these key numbers, these parameters, that point us directly to a specific problem and its solution. The R time tells you how long it takes for the clot to even start forming. The K time and the alpha angle show how fast the clot builds up its strength. The maximum amplitude, or MA, is the clot's ultimate strength. And finally, LY30 tells you how much of that clot has broken down after 30 minutes. Okay, Section 4, from tracing to treatment. Let's put all that data into action. So, let's try a scenario. The TEG starts running, and you see the R time is really long. The line on the graph just stays flat for way longer than it should. So thinking back to our parameters, what part of the coagulation system is failing here? You got it. It's a problem with the coagulation factors. A long R time means that initial spark, that enzymatic cascade, just isn't happening properly. So what's the fix? You give the product that has all those factors in it, fresh frozen plasma, or FFP. See, it's goal-directed therapy happening in real time.
All right, let's do another one. This time, the R time is totally normal. The clot starts on time. But the tracing that forms is super narrow. It's a skinny little shape. The maximum amplitude, or MA, is low. What's the likely culprit now?
That's right, it's a platelet problem. The platelets and fibrin are what give a clot its physical structure, its strength. A low MA means you've got a weak clot, which usually means you either don't have enough platelets or the platelets you have aren't working right. The guided treatment? A platelet transfusion. You're not just throwing the kitchen sink at the patient anymore, you're treating the specific defect you've identified.
All right, moving on to our last section, the promise and the limitations of TEG, because it's absolutely crucial to have a balanced clinical perspective on any tool we use.
So where does TEG really shine? Well, the evidence is pretty solid in a few key areas. Studies show it can reduce the amount of blood products used in cardiac surgery. It's an absolute lifesaver for managing the crazy coagulation problems you see in liver disease and transplants. It's also used to manage anticoagulation for patients on ECMO and to see how well antiplatelet drugs like aspirin are working.
But, and this is a big but, it is not a magic bullet. The evidence in trauma is actually still pretty mixed. And it's not great for monitoring warfarin. The INR is still the gold standard there. You also have to remember, this is an in vitro test. It's happening in a little plastic cup, not in a human blood vessel, so it misses all the important biology of the vessel wall itself. And that brings us to the most important rule of all. You treat the patient, not just the test. An abnormal TEG in a patient who is stable and not bleeding does not automatically mean you start transfusing. This really points to an exciting future, though, a future of truly individualized healthcare. Instead of just giving everyone the same dose of blood thinners, TEG gives us a potential way to tailor that therapy to each person's unique response, letting us see if they're resistant or maybe too anticoagulated before a real problem happens.
And that leaves us with one final thought. We started this journey in the chaos of a massive bleed, and we've seen how a test that was invented over 70 years ago can bring incredible clarity to that chaos. So the question is, as this technology gets even better, will point-of-care tests like TEG finally make the one-size-fits-all approach to managing blood clotting a thing of the past? That's the exciting future it invites us to think about.